morning, everybody. I'm Pat Stone. I'm the Director Center for Health Policy here at Columbia School of Nursing, and of course, the Center for Improving Palliative Care for multiple adults with multiple chronic conditions, or SIPC, as we call it. This is SIPC's year-end event entitled Multicultural Issues in Palliative Care. Our panel discussion today is particularly special. It's the last SIPC year of SIPC funding of our NIH funding. And given this, I really want to take some time to celebrate what we've done for 5 years of SIPC. It's been really incredible.
So hi to everybody. This is Billy Rosa. I just thank you for your patience as I took the time to re-record this keynote presentation, which was given at the SIPC final event at Columbia School of Nursing a few weeks ago. And I know it was inaudible on Zoom, and unfortunately I didn't know that until the end of the presentation. So thank you for your patience as I re-recorded this for all of you, and I hope this finds you well wherever you are. And in leading up to the conference and the theme on multicultural issues in palliative care, I started thinking about advocacy and how we take the amazing research of the other scientists that we heard that day and the exceptional clinical wisdom of so many of the experts we work with. And we actually move that toward policy change, and we actually use that to improve clinical outcomes for the patients and the communities we serve. And it really takes advocacy in order to do that. And so I was thinking about what it actually takes to be a good advocate. And what it takes is really being aware of who we are and bringing our full self to the table, our purpose, our skills, our talents, being aware of our vulnerabilities and our weaknesses. And so I had been really reflecting on this quote leading up to the conference, and it was by a Greek poet, Dinos Christianopoulos, who was actually marginalized by the literary community in Greece some decades ago because of his sexual orientation as a gay man. And he wrote a poetry couplet at the time that has been used in many social advocacy movements today and adapted. And it reads, "They tried to bury us, but they didn't know we were seeds." And I think it's such a powerful quote as we start to think about how we use all the parts of ourselves to actually move toward justice and inclusion in palliative care across cultures, across contexts, and use the parts of ourselves that maybe have remained hidden, right? Because those are the most precious parts of ourselves. They're the most human parts of ourselves. Those are the parts that will likely be able to create the human-to-human connection with decision makers who are also human beings and who also have experiences that need acknowledgement and listening to. And I started with some cultural disclosures in an attempt to really equalize the space and really be transparent about the worldview that I bring to this conversation. And so I come to this as a researcher who's primarily invested in health equity research and palliative care. So I focus on cancer pain disparities for racially minoritized groups and LGBT inclusive communication in serious illness. And a good chunk of my work is also focused on global palliative care and the global inequities in access to pain relief. And I'll talk about that more in a few slides. I come to this work as a clinician of 14 years, having worked in critical care and global health and oncology settings, really witnessing firsthand the downstream effect of inequities. And witnessing the vast unmet need that needs advocacy the most. And of course, as somebody with multiple interlocking identities, right? Somebody who has lots of identities of historical privilege. I'm a white cisgender man who's highly educated. I live in a middle-class neighborhood in New York City with easy access to organic food and public transportation and healthcare services and parks. And I don't have a serious illness, and I'm not a caregiver. And so I'm able-bodied. I come to this with incredible privilege that allows me to navigate the world with really just no questions asked. And I have some identities of historical exclusion, like being a gay person who's experienced traumatic bias and violence, and a first-generation college student, and a man in a predominantly female field of nursing. And I'm aware that I'm speaking to people who have lots of different social locations and come from many, many different worldviews. And so as we talk about multicultural issues in palliative care, and we talk about advocacy and how we actually rise toward justice and inclusion, I have 3 invitations that I'd like you to keep in mind during this brief presentation. The first is to use the time to become aware and reflect on your own social location, where you are in the world, the factors that determine who you are, how you show up at the table, and how you're received by the people around you. The second invitation is to create an accountable space, and there's 4 parts to that. The first is to equalize the space, recognizing that everyone has equal worth and all perspectives are equally valid, really encouraging you to make space for yourself, to take space. The second is to check your assumptions. So use I statements when sharing your own perspectives. Really believe that the common best intentions are what is present here. This is my favorite as a palliative specialist and nurse, of course, but the right to be human. I often put my foot in my mouth, and my request starts with an acknowledgement that I likely will unconsciously offend or misspeak today. And so I always ask that people call me into awareness rather than calling me out in shame, so that we can actually grow in community rather than growing apart in isolation. And so a part of this is recognizing that everybody's human. Everyone will have a bad day. People show up to these very difficult conversations, having been triggered by something else, being particularly sensitive, being stressed by something else going on in their life. So it's really an opportunity to practice and receive forgiveness. And the last part of this is consensual dialogue, which is palliative specialists where let's say that's a strength, right? So I encourage you to use active listening and really recognize the 50% rule, that everyone is 50% of the problem and the solution. And bringing these skills together is how we create an accountable space and accountability in advocacy. And the third invitation is to really be aware of where you are each step of the way, right? Some self-care, really important. So what's your comfort zone look like? Mine looks like an ice cream sundae, which feels great, but not an ideal situation to learn in, right? So be aware of how these conversations activate you, maybe how they stress you out, and be aware when you may be getting into this stress zone, right? Feeling some of these things like frustrated, fed up, anxious, just annoyed. And make sure that you take a walk, take a break, put me on mute. Lots of people would love to put me on mute. I won't be offended, but do what you have to do to take care of yourself so that you can really stay in this learning zone with us, right? And so as I begin this talk, I just want to start with a note on suffering, because so much of palliative care has to do with suffering, being with it, witnessing it, seeking to alleviate it. And yet there are tremendous disparities in who suffers, how they suffer, why they suffer, and the barriers they face in getting alleviation for that suffering. And so I want to read 2 case studies side by side. And I'll just give you the opportunity to kind of listen to all of the disparities that inform how suffering is so different for each of these people and for those around them who care for them and love them. And so the first case is Matteo. So Matteo was a scientist and a physician by background. He was in his 60s with a history of stage 4 lung cancer. And throughout his journey, Matteo suffered from progressive dyspnea, despite empirical treatment with antibiotics, with steroids and oxygen. And his disease continued to progress. And when we met him, he had just had 2 back-to-back hospitalizations that had really exacerbated his physical deterioration. And it became evident that Matteo was nearing the end of his life. So he was dependent on high-flow nasal cannula, which really made discharge home impossible, but discharge to an inpatient hospice was really incompatible with his values. So it was unacceptable to him, and our palliative care service was consulted. Now, Matteo is divorced with 2 children. He had a daughter in her early 20s, a son in his late teens, and he planned to see his children the next day to say goodbye. And he asked that after his children left, that we remove his oxygen, with full knowledge that he would likely die soon after that oxygen removal. Importantly, he was in a long-term relationship with Angela. He expressed feeling fully alive in Angela's presence. He felt appreciated, dignified, This relationship really allowed him to engage in personal emotional healing for the first time in his life, and he reported feeling spiritually at peace, and he just wanted comfort and ease. And so the next day after he said goodbye to his children, we sat with him. I sat with him at bedside. He looked in my eyes. He said, "I trust you." And he laid back in bed, and we began the weaning process. And he died only a handful of minutes after his oxygen was removed, as we'd anticipated. And following his death, the team really took time to debrief and cry together and grieve together. We sat in a room and acknowledged each other and spent the following year writing and debriefing and presenting on this powerful case that really did change all of us for the better in so many ways. And so as you listen to this, I just invite you, wherever you are in the privacy of your home or office, to just take a breath. Really, take a breath. Let that case go, because it's powerful. And I'm going to move on to a second case, quite different. And this is the case of Ashley. So Ashley arrived at the emergency department following a motor vehicle accident that resulted in a loss of consciousness and the need for mechanical ventilation. And Ashley was admitted to the ICU in critical condition. A referral to specialty palliative care was never ordered. And once on the unit, clinicians discussed with confusion that Ashley had male genitalia and wore makeup and nail polish. Paramedics reported that she was wearing, quote, women's clothes at the scene, which were removed while preparing her for transport to the hospital. The driver's license identified Ashley as a Black man of 30 years. And Ashley's mother, her legal next of kin, received notification of the accident by the police, arriving at the hospital within a few hours. So she was noticeably distraught and reported that she had not spoken with her son for several years, asserting that he had begun to hang out with, quote, the wrong sort of people. News of Ashley's accident spread among her friends, who arrived at the hospital soon after. And Ashley's mother denied them access to the patient, calling them, quote, sexual deviants. The friend shared with the healthcare team that Ashley identified as a trans female and was part of a close-knit community. And several hours later, Ashley suffered a cardiac arrest requiring CPR. Now, during the code, while surrounded by the code team, other team members, several trainees, the lead physician interjected, "What's up with him wearing women's clothes and nail polish?" Ashley died of complications of the accident, having never shown outward signs of regaining consciousness. A nurse in the ICU provided postmortem care. Ashley's mother never came to the bedside to say goodbye, but she also didn't let Ashley's chosen family see her either. Grief counseling and bereavement services were offered to the mother, which she declined, but no services were offered to Ashley's friends. And the team left distressed and disturbed by the interpersonal breakdown and all of the complex clinician-family dynamics that provided barriers to compassionate care delivery. And I'll invite you just again to take a breath and let that go, because that's a lot to hear. It's a lot to take in. And what I'm struck by when I read these two cases side by side is, as I mentioned earlier, all of the disparities in suffering and how suffering transpires in the clinical setting. The disparities between Mateo and Ashley, you know, on one hand, seeing a very normalized end-of-life situation, ethically challenging, yes, but normalized, versus the stigmatized experiences of Ashley. We had a white cis man in Mateo and a Black trans woman in Ashley's case. Clear agency and directives on the part of Mateo, right? Really clear on his values. Whereas Ashley, an unconscious patient, had no history of advanced directives or documentation or prior conversations with health workers. There was this planned and organized approach to Mateo's care in one hand, and a very confused emergent response that was quite incoherent in Ashley's case. The family in Mateo's case was invited, was centered, and Ashley's chosen family was quite marginalized and excluded from all of the situations and excluded from a healthy grieving process as well. And then there was the effect on the team, which in Mateo's case led to cohesion and healing and growth, you know, improved communication. And in Ashley's case just led to breakdown and distance and dissolution. And so it really makes you think about all of the reasons we need to advocate for improved care. In a few months' time, I have a book coming out with Dr. Betty Farrell, and this is a second edition of her seminal text with Dr. Nessa Coyle that was published in 2008. And we've increased the book from 5 chapters to 18, and we have more than 30 authors, experts, researchers contributing really to provide a qualitative volume on the nature of suffering and really pragmatic takeaways for how nursing can attend to that suffering. And there's one incredible chapter by Dr. Shuk Naruna Naspina from the University of Washington on social suffering and how we've all become so naturalized to inequality that we oftentimes can't even see it. And they give 3 pragmatic takeaways for any nurse working in any setting to really start to dismantle this naturalization of inequality. And the first is critical conscientization. And yes, that is as hard to say as you can imagine. Very proud of myself every time I say it correctly. But critical conscientization, right? Conscious self-reflexivity, where we really think about our privilege, where we really examine the assumptions that perpetuate systems of oppression. And we kind of adopt this critical stance to apprehend the politics of suffering, right? What we do is not apolitical. So becoming aware of that, educating ourselves about structural competency as the, really the host of issues that inform the experience of suffering at structural levels and how they trickle down to the suffering we witness in clinical care. And finally, advocacy, activism, and allyship. And so, we could spend all day talking about these 3 items, but I want to focus for a moment on advocacy. And I'll start with one definition, one formal definition of advocacy. And it's the processes by which the actions of individuals or groups attempt to bring about social and or organizational change on behalf of a particular health goal, program, interest, or population. Health advocacy includes educating policymakers and the public about evidence-based policy. And it's a beautiful definition, but I see it much more simply than that. I think advocacy is more about being really clear about who you are and where you are, right? Your social location, the parts of yourself that have been buried, either by society or by your own choice, being really clear on the barriers you face, and being clear on where you want to be, which hopefully is a just and liberated health system where we can deliver equitable palliative care services and alleviate suffering for people in equitable and inclusive ways. And so a few years ago, colleagues and I from the Center for the Advancement of Palliative Care and the International Association for Hospice and Palliative Care wrote this article that I'll refer you to if you want to read more on this topic. But I've kind of adapted a few of these tips for us today to just think about in the brief amount of time that we have. What I want to acknowledge here is this vital feedback loop that Pettis and DeLima talked about between clinical practice and advocacy, right? The everyday, like I said earlier, exceptional wisdom that's gleaned from clinical practice and how that informs advocacy that happens at all levels of governance, right? From the unit and service level all the way through civil society. And it's ultimately that advocacy that leads to change policy that will inform improved practice in the future. And this is an iterative, ongoing, continuous relationship. It is not a one-stop shop. And one of the things I want to emphasize here is as you advocate, as you communicate to decision makers, it is ultimately the data plus the stories that really make you memorable, right? It's that empirical data that really explains the vast unmet need of populations and the stories of human experience, the stories of how that occurs in everyday life on the ground that decision makers will remember. And nobody's better positioned to do that than palliative care clinicians. And so I'm going to use global palliative care as a little bit of a background and an exemplar of how we do this advocacy, right? But I'll give you just a little bit of context first. The first thing I want to say is that palliative care in the global context, palliative care and pain relief is virtually absent, right? The suffering of the poor is pretty much invisible on the global stage. And that's really important to remember. And so we're talking about basic humanity, basic pain relief, basic, if any, spiritual and social care, et cetera, right? We're not talking about an integrated model of palliative care that we often see in the United States, or that at least we strive for. And so in the global stage, we know that about 57 million people every year worldwide need palliative care. And actually, our most recent data says this is over 68 million. This is actually old data at this point. About 88 to 90% of palliative care need is unmet, which is incredible to think of. 2/3 of countries have no or extremely limited provision of palliative care. Over 75% of adult palliative care need exists in the poorest countries. Over 80% of countries have low to no palliative care, low to no opioids for pain relief. And this is really important in the global palliative care context because we use opioids as a tracer for palliative care access, right? Very difficult to palliate symptoms, moderate to severe pain, or breathlessness at end of life when we don't have the controlled essential medicines that are needed to do that. And the burden of health-related suffering that is thought to be amenable to palliative care is expected to increase nearly 90% over the next 4 decades, primarily affecting the poor and people over the age of 70. And back in 2018, the Lancet Commission on Global Access to Palliative Care and Pain Relief published a seminal report. And they did a few things that were quite remarkable. The first is that they actually looked at 20 health conditions that were thought by this global expert panel to really produce the highest burden of symptoms and quantified serious health-related suffering that could be relieved with palliative care around the world. So they quantified serious health-related suffering, or SHS. The next thing they did was they looked at the legal distribution of opioids using International Narcotics Control Board data. So distributed opioid morphine equivalent, or DOM, which again, they used as a tracer for palliative care access. And then by looking at a ratio of suffering to DOM, they were able to estimate the percentage of potential palliative care need that was met around the world. And they produced this map, which you can see the size of certain areas is quite different because the size of each region is proportionate to their access to palliative care. So this is a distribution of opioid morphine equivalent. So you'll see that North America looks quite engorged, while other parts of the map are quite invisible even. And so the way we read this is we say that a country like the US, and again, this is just legal distribution. This is not consumption. This is not the illicit drug trade. We say that people in the US in need of palliative care have access to about 56,000 milligrams of morphine equivalent per patient in need of palliative care each year, exceeding the need by over 3,000%. Whereas in a country like Nigeria, less than a milligram per patient in need of palliative care each year, which basically doesn't meet any of their national need, right? 0.2%. And then you see entire regions of the map, again, South America, most of the continent of Africa, East Asia, just almost completely invisible. And so the takeaway here was that 50% of the world's poorest populations live in countries that receive less than 1% of the annual distributed opioid morphine equivalent. But the richest 10%, those of us in the US, for example, we live in countries that receive more than 90% of the DOM, right? So this 10-90 divide is quite remarkable and quite a moral travesty. And that was a cross-sectional analysis. And now in our unpublished data that's soon to be disseminated, we can actually look over time at how the ability to relieve suffering has changed. So on the y-axis, we have the percentage of potential need met. We have our 30-year retrospective on the x-axis for our time series analysis. We can categorize countries by income level, and we can start to tell a narrative, right? So looking at low-income countries, for example, virtually no change in their ability to relieve suffering over the last 30 years. Same for lower middle income countries. When we look at upper middle income countries, we can see a 6-fold increase from 4% to 25%. But again, quite the moral travesty, 25% of their national level suffering in these upper middle income countries can be alleviated. But if you look at high income countries, just looking at 2010 and 2019 alone, we exceed our ability, our need for palliative care by 1,000 and 600% respectively. And so actually the disparity between high income and low income countries was so great that the only way we could get them to fit on the same graph was by adding that little squiggly line that you see. And then we can start to tell national level narratives. So we can look at opioids, for example, by type. We can look at the percentage of palliative care need that is actually met. And we can start to put it in the context of policy and practice, right? So Uganda, for example, we can see that they've had vast increases in off-patent morphine access over the last 30 years, mostly due to government investment in nursing education. For prescribing morphine and monitoring it. And by the way, I should say that off-patent morphine is the international recommendation for increased opioid access because it really takes the profit motive out of the drug trade. And you can see accordingly on the bottom left that they've increased in their ability to meet need over time, now being able to meet about 15% of their national needs. So we can do that for countries around the world. But we know that the disparities don't only exist in practice, but they exist in the science. So colleagues and I, last year for Lancet Public Health, we ran a librarian-assisted bibliometric review where we pulled 32,000 articles related to opioids and pain management. And basically what we found is that 1090 divide right there in the literature. So just about 10% of the articles focused on opioid access and pain disparities, but over 90% focused on opioid addiction and use disorder. And so the implication here being that we don't need less research on opioid addiction and misuse, but we need more research on opioid access and the inequities that cause many of the poorest people in the world to suffer more and suffer disparately. So let's talk about how we would do advocacy here, right? So pretend you're an advocate and you're speaking to the Department of Health and Human Services, and you are advocating for them to support policy that would advance universal palliative care access around the world. So you might start with a regional or global perspective. You would share some of the global level data. You would say, let's take Africa for instance. When we think about Africa, did you know that Africa accounts for about 20% of the adult palliative care need around the world? And when we think of the pediatric palliative care need, they account for nearly 52% of that need, right? Huge inequities when we think about comparison to high-income countries. And this is mostly due to progressive non-malignant disease in children. In adults, you can see almost 80% of it is due to HIV. And then we might hone in at a national level and say, you know, our research in Nigeria shows that about 50% of all the patients who die each year have suffering that could be relieved with access to palliative care. And that doesn't account for the almost 3 million people who actually have suffering, but are not at the end of life, right? They're living with serious illness, non-decedents. So we actually estimate that there's a total of 3.6 million people in Nigeria each year who need palliative care, but we worry that they're not able to get it. And we would start to tell country by country narratives, sharing with them what's going on in Uganda, showing them that map that I showed earlier where 0%, where Nigeria is able to meet 0% of its need. And I would start to show the dissonance between that data and the policies that are put forth by the Ministry of Health in Nigeria that really say that every Nigerian should have equitable access to palliative care as a component of universal health coverage. And so I would say we need better research about the learning needs of the workforce, how we move this to the ground. We should have monies to conduct a country-level analysis of palliative care need, but in the context of available resources and insurance schemes. And we should do some qualitative investigations with stakeholders in the community and professionals to really see what the barriers to palliative care uptake and readiness are. And the decision might say, but how do we do a country level analysis? That sounds so difficult. And I would say, you know, it's funny you should ask because we just published a paper where we did this for Chile. And we looked at 2019 government data. And basically what we looked at was cancer and non-cancer, decedent and non-decedents. And we found that there were 105,000 people in country every year approximately that had suffering amenable to palliative care. Now, the issue in Chile is that palliative care is included as a financial protection in the insurance package. So basically about 42 people of the patients in need had cancer, and so palliative care was a financial protection, but about 61,000 people lacked palliative care coverage. And by costing the most basic palliative care services, we estimated that universal access would cost about 123 million US dollars, which is really just 0.47% of the Chilean national health expenditure. And so not only is it feasible, but it's inexpensive, right? It's really possible. And that decision maker might say, but how do we actually educate the workforce to move that toward reality? And I'd say, you are reading my mind, because we did a study in Rwanda where we surveyed 420 nurses and physicians across 5 hospitals in Kigali. And we really assessed their learning needs and their self-perceived efficacy in palliative and end-of-life care. And unsurprisingly, they really perceive their knowledge and skills in palliative and end-of-life care as quite low. And pain management in particular was identified as an educational need by 77% of those nurses and physicians. And then as we talked, I would step back and say, but it's really important to remember that while this empirical data is important, this human narrative is really how it shows up on the ground. And I would share this testimony from Dr. Raja Gopal that was provided for the Lancet Commission report, where he told the story of Mr. S. In agonizing and crippling pain from lung cancer, Mr. S came to the palliative care clinic in Kerala from an adjoining district a couple of hours away by bus. His body language revealed the depth of his suffering. We put Mr. S on morphine, among other things. A couple of hours later, he surveyed himself with disbelief. He had neither hoped nor conceived of the possibility that this kind of relief was possible. He returned the next month, and yet common tragedy befell the patient and the caregivers in the form of a morphine stockout. Mr. S told us with outward calm, "I shall come again next Wednesday, and I will bring a piece of rope with me. If the tablets are still not here, I'm going to hang myself from that tree." He pointed to the window, and I believe he meant what he said. And so what I want to reflect on with you is that whole piece of advocacy took less than 5 minutes, right? From the global Africa continent data all the way to the human story. And I started by saying, let's pretend you're an advocate, but this is actually part of the advocacy we did with the International Association for Hospice and Palliative Care a few years ago, working with the Department of Health and Human Services and advocating to the Office of Global Affairs. And because of that advocacy and because of how we had those conversations, we were really able to ensure that palliative care was included in the executive board meeting of the WHO 2021 meeting on the resolution of the highest attainable standard of health for persons with disabilities. And so ensuring that palliative care is actually included in the resolution holds member states accountable for actually delivering, right? So you can see here that the health needs of persons with disabilities need to be met across the life course through comprehensive preventive, promotive, curative, rehabilitative services and palliative care, including psychosocial support. That is a major, major advocacy win. And so what I want to impress upon you is, as we see these disparities, it's so easy to see opportunities where humanity is divided and where dignity around the world is so buried, right? And as we think of multicultural issues and how we can use advocacy, I just want to remind you that no matter how hard they may try to bury you, but you really are the seeds. So please do hold fast to the amazing research and the exceptional clinical wisdom that you hold. And I really encourage you to further hone those advocacy skills that bring those seeds out into the daylight. But what I hope you will remember is that even though they may try to bury you, you really are the seeds. Thank you. And so I am going to introduce our incredible panel. I'm going to stop sharing my screen. I'm not sure I know how to stop sharing the screen. There it is. Okay, no more share. Great. So my pleasure to introduce our panel. So we have Gary Stein, Dr. Gary Stein, who is a professor at the Wurzweiler School of Social Work, Yeshiva University, where he's a tenured faculty member in the master's and doctoral programs. He's also the director of the gerontology and palliative care programs for MSW students and for clergy and continuing education. He's PI of the study Project Respect, LGBTQ experiences with healthcare providers for serious illness.
We have Dr. Tamryn Gray, who's an instructor in medicine at Harvard Medical School within the Department of Psychosocial Oncology and Palliative Care at Dana-Farber Cancer Institute and Department of Medicine, the Division of Palliative Medicine at Brigham and Women's Hospital. Dr. Gray is a health services and palliative care researcher who employs mixed methods, big data, and implementation science to investigate the complex medical, decisional, psychosocial, and socio-epidemiological factors influencing care delivery and health outcomes for patients with serious illness and their caregivers. And we have Dr. Leah Estrada, who defended her dissertation in June, and is an instructor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai here in New York. Dr. Estrada holds a joint appointment as a nurse scientist within the Center for Nursing Research and Innovation at Mount Sinai Hospital. Dr. Estrada received her PhD in nursing in 2022 from Columbia University School of Nursing, where her dissertation was on palliative care services and potentially avoidable hospitalizations for historically marginalized nursing home residents approaching end of life across the United States. And I'm going to hand it over to Dr. Gary Stein.
Okay, thank you, Dr. Rosa. That wonderful introduction. Can the people online hear well? Yes, good, yay, okay. Let's see. Good morning, everyone. I'm Gary Stein from the Wurtzweiler School of Social Work. I'm so pleased to be addressing you this morning. I will be presenting over the next 20 minutes my and my colleagues' study, Project Respect, LGBTQ+ experiences with healthcare providers for serious illness. Questions to ponder as we begin. What is the personal impact of discrimination? How does discrimination impact communities? And how do healthcare providers help or hinder patient care? I come to this work largely as a result of my personal background. I am a gay man who came of age and came out just prior to the HIV epidemic. Soon after coming out while in graduate school, I was the victim of anti-gay violence, which taught me to be vigilant and not to rely on others to stick up for our community. My career choices have largely been influenced by being gay, fortunately keeping me in areas of greatest interest. From the HIV epidemic, I learned that discrimination went hand in hand with patient care, and that the LGBTQ community must lead in meeting our own needs. As my interests evolved from HIV care to palliative care, I sought to bring LGBTQ community perspectives to our field. With that is the personal. I've been with my husband for 43 years. One of us will survive the other and will not have his advocate and partner. I think about the care system that will be in place for us, our friends, and our community. Can we address the discrimination that is part and parcel with our systems of care? Okay. So with that, I go to our study. I have no conflicts of interest to declare. Okay. And this study has been supported in part by the generous support of the Borchardt Foundation Center for Law and Aging in California. Okay. Our research team includes myself as principal investigator and my colleague, Dr. Kathy Berkman of Fordham University, who is co-PI. We have a fairly large and diverse research team from all over the country, including Dr. Billy Rosa. Okay, some background. The LGBT community has a long history of discrimination and stigma, including in the delivery of healthcare and social services. GLAD, an organization which does an annual poll that should read 2022, has documented a decline in acceptance for the LGBTQ community that began probably around 2016 with the Trump administration, and increased reports of discrimination and hate crimes. There is scant data on LGBTQ patients and families in hospice and palliative care, and this is especially so for the transgender community. Our community is hesitant to disclose information about sexual orientation and gender identity, fearing how they will be received. And this is especially for older adults who have experienced stigma, victimization, discrimination, and criminalization during their lifetimes. Discrimination concerns may lead to delaying or avoiding health care. Transgender patients have high levels of mistrust of their healthcare providers. Bringing us to our healthcare provider study, which has been published in the summer of 2020 in the Journal of Palliative Medicine. We did a survey of healthcare providers from the major palliative care professional associations. You'll all be glad to hear 40% of our sample included nurses, and then about 20% each of social workers, doctors, and chaplains. We sought to get information on how staff thought and perceived discrimination was occurring regarding LGBTQ patients, okay? Over half thought that LGBT patients were more likely to experience discrimination than patients who were not LGBT. And almost 2/3 thought that transgender patients were more likely to experience discrimination than patients who were not. Then going to observations of actual discrimination, 1/4 of our sample actually observed instances of inadequate, disrespectful, and/or abusive care towards LGBT patients. And about 1/5 of our sample had observed instances of inadequate, disrespectful, or abusive care to transgender patients. Examples of disrespectful care. End-of-life LGBT patients were asked not to show public affection. A case manager referred to patient's transgender partner as it. And we've heard this frequently in our comments. During a code situation, staff made jokes about what pronoun to use for the patient. The medical record did not reflect gender or the patient's chosen name. Regarding inadequate care towards LGBT patients, the nurse refused to provide care because he was a gay male. They let soiled diapers stay on too long. Staff traded off treatment due to religious reasons. And on refusal of care to transgender patients, they said lack of physicians who will treat trans people, and a home health aide refused to be placed in the home with the patient. We asked about the discriminatory actions that were observed towards spouses and partners. 15% observed treatment decisions being disregarded or minimized. 14% reported being treated disrespectfully. 9% reported being denied or having limited access to the patient in intensive care or the emergency department. And you could see there are those lesser percentages of people being denied private time, having visiting hours limited, and fortunately, only 1% reported observing being treated abusively. Examples of ignoring the spouse or partner: not including the partner in family meetings or decision-making, nurse prioritizing the mother as the decision-maker against the patient's wishes, estranged family members being brought in at the end of life for decision-making, and excluding partner in exam and discussion when the patient wanted him present. As a result of this study with providers, we concluded that there's strong evidence that LGBT patients and partners face a greater likelihood of discriminatory care. As a result of these findings, we decided it was now time to reach out to patients and their partners to get a sense of what they personally experienced while receiving care for serious illness. The purpose was to learn about perceptions of disrespectful and discriminatory care, and this is care that's gone both towards the patient as well as towards the spouse, partner, or the widow. For our methods, we used an online survey that was conducted anonymously and took about 15 minutes to complete. The study was mixed methods. It include opportunities through open-ended questions to provide more in-depth responses to our questions. Our respondents included seriously ill LGBTQ individuals, as well as the spouses, partners, and widows of a seriously ill LGBTQ person. Our sample was recruited from organizations serving the LGBTQ community, elder care organizations, healthcare organizations, including hospice and palliative care, and medical centers. We used websites, social media, newsletters, virtual and physical bulletin boards, and word of mouth. And we also had a graduate MSW student who worked tirelessly to reach out to LGBTQ organizations and senior centers across the country. This is a copy of the flyer that we used to announce our study. Our measures were discriminatory care to the patient and to the spouse and partner. We also asked questions about good care. We wanted to hear about the good examples of care, but again, both to the patient and to the partner. Our description, we have 290 individuals that make up our sample. 173 of them are patients, 82 are spouses or partners, and 35 are widows. A diverse gender spread, 40% of our sample were female, 35% male, and about a quarter of our sample were either transgender or gender non-binary. Sexual orientation corresponded very well to gender. We have a diverse age range for our sample with a very large group at the younger and early middle age years. And we also had people in our sample up to 89. We have a diverse group by race and ethnicity. 26% of our sample were people of color and 72% were white. 25% of our sample were Hispanic or Latino. Our sample was spread in regions throughout the country, with the largest number, almost 40%, in the Northeast and the second largest number in the West and Pacific. A broad range of illnesses were represented by our sample, with 28% of our patients having cancer. Also a broad range of settings of care, with largest numbers of receiving care in a doctor's office or outpatient, or in a hospital inpatient facility. Our results. We looked at our results by two areas: for the healthcare providers and support staff, who included home care aides and other healthcare aides. Over 1/3 of our sample reported that they received insensitive care due to being LGBTQ. And about a third said that their provider was not aware of LGBTQ health needs. And about a quarter to 20% said the patient was made to feel judged for being LGBTQ, the provider was rude to the patient, or that they did not use correct pronouns or disregarded the patient's treatment decisions. Partners also reported levels of discriminatory care. 12% said that they were denied access to their partner in the ICU or ER, and the same number said that they were treated badly. About 10% said that their decisions about their partner's care were not followed. I will skip over these. Okay. Examples of bad care to patients. I have had so many poor experiences with healthcare providers because I am LGBTQ. Staff often act awkwardly around me once they learn of my sexual orientation. It's enough to make medical care more stressful for me. I've never disclosed my LGBTQ identity because I'm in a rural area and they have done nothing to indicate that it might be safe to do so. Examples of bad care to trans patients. The doctor ignored my repeating asking to be referred to in gender-neutral terms. I never mentioned being genderqueer to a doctor's office again. Upon the doctor entering the room, she asked, "What are you doing here?" And before I could complete my answer, she added, "We don't do trans." I've been called it and he by many healthcare providers. When hospitalized, they refused to let me have hormones. Examples of bad care to the partner. She has been told she had to wait in the waiting room instead of accompanying me in for procedures when other spouses are. My spouse did not feel she was very seen or included. Having to explain who I am when it is to the record that I am the spouse. My partner's gender was not recognized by staff, and staff assumed we were either a heterosexual couple or that my partner was my parent. Some examples of good care to the patient. My husband has nothing but respect. My physician has nothing but respect for me and my relationship. When my husband died, she came to his funeral and offered helpful resources for widowed LGBT folks. It meant the world to me. The entire team was respectful and sensitive to me as a person of color and being gay. Glad to say this one, the palliative care representative is outstanding. They have treated us with respect and professionalism always. More examples of good care. My doctor spoke to the hospital at my request to let them know I wanted my partner respected and given full access to me, and they did respect her. My husband was permitted to accompany me to all doctor and hospital procedures. He is a full part of my support team. Skip over that. There are many implications of this study for practice and for policy. Consistent with the healthcare provider study, we find that there are strong evidence that LGBTQ patients and partners receive discriminatory care while receiving care for serious illness. But there's also many reports of respectful, affirming, caring, and competent care. Lots of trends in state policy going on at the moment. The ACLU has been surveying the numbers of anti-LGBTQ legislation that is being introduced and considered around the country. A week ago, when I was doing this report for HPM, there were about 409 examples. Yesterday, when I checked, there were 449 examples. So there were 50 new bills proposed in just the last week alone, primarily in red states across the US. I have seen a lot of LGBTQ discrimination over the last decades during my life. I am shocked by the degree of cruelty that's currently going on in red America today. Physicians and parents, proposals include criminalizing physicians and parents for gender-affirming care for trans youth, repealing state laws prohibiting conversion therapy for LGBTQ youth, and censoring discussions and reading materials in schools about sexual orientation and gender identity. There are only 22 states and the District of Columbia that provide civil rights protections based on sexual orientation and gender identity. These states are mostly located in the Northeast, the West Coast, and the Upper Midwest. There needs to be a lot of advocacy to have laws passed in the other half of the country, as well as at the federal level to have the Equality Rights Act passed. Staff training is greatly needed to increase the competence of working with LGBTQ persons, to promote sensitivity, compassion, comfort, and respect, to address medical, psychosocial, legal, and spiritual issues, and to train staff on how to ask about sexual orientation and gender identity, as well as important relationships. Organizations need to take major actions. They need to be developing institutional guidelines that create safe environments for LGBTQ patients and families, as well as strategies to identify, report, and respond to discriminatory care. I'd like to conclude with a comment from someone who completed the survey. Thank you for this survey. With the unbelievable events taking place in Texas and many other jurisdictions seeking restrictions on LGBTQ children and adults, we need to keep our community strong and protected. Bigotry will not win the day. So I'm optimistic that eventually that will be so. Here is the reference to our JPM article. And if there are any questions, you could reach me at my web address or my email address. Thank you. I'm pleased to invite to the podium Dr. Tamryn Gray.
Thank you so much, Gary. Hi, everyone. My name is Tamryn Gray, and it is a delight to be here today. I come to you with a couple of different identities. First, my grandparents did not finish elementary school. I come from the Deep South. I currently live in the North in New England. I also came from a high school where there were over half of the student population students of color, with high food stamp recipients. I'm also a first generation college graduate, the first in my family to hold a doctorate degree, but also come from a loving family with a twin sister. And I thank you, my mentors and my family members and friends a lot who are online today supporting me. So today I'll be shifting gears, talking a bit about family caregivers. And it's very exciting because we often don't take a moment to really think about how diverse family members are, particularly those who care for people with serious illness. These are my current funding sources and disclosures, the most important being at the bottom. I'm a daughter caregiver to my father, who has some complex medical issues and is an amputee. So today we'll be talking about the current state of family caregivers in the United States today, and particularly regarding the diversity and diverse needs of family caregivers. Second, we'll be talking about resources and policies that really impact family caregivers and that are available or not available to families of underrepresented and marginalized backgrounds. And then finally, we'll be introducing the role and contributions of palliative care in supporting the increasingly diverse family caregiver population. So for a lay of the land, there are currently more than 53 million family caregivers in the United States today, representing 1 in 5 households. These individuals provide unpaid care and support to a family member or friend. And you can see here, there's a couple of trends that are happening when it comes to the caregiver population. First, we know that this number is continuing to grow due to the aging population, individuals who are having less children, as well as individuals who are going home with long-term and complex needs. We also know that caregivers are becoming increasingly diverse, and that reflects a lot of the nation today. And then finally, we see that care provided by family caregivers is often driven by a considerable cost to caregivers themselves. And this could include financial, emotional, physical, to name a few. And not surprisingly, the coronavirus has really made life more difficult for caregivers and their care recipients. More than 4 in 10 caregivers report spending more time per week and more money on their caregiving responsibilities because of the pandemic. So in terms of level setting, who are caregivers? So these are individuals who assist family members and friends by providing care and support during illness. And the graphics below really talk about kind of some considerations that we must consider when we think about family caregivers. They're spending a lot out of their own pockets. A lot of healthcare today is shifting outpatient, which is increasing the burden for family caregivers. And caregiving requires a lot of time and effort for these individuals. So how does caregiving impact daily life? Well, we can see from the slides here, if we follow on the top left, Rosalind Carter once said, there are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who need a caregiver. We also know from AARP that approximately 38% of family caregivers report spending more than 25 hours per week providing unpaid labor. In addition, 60% of family caregivers report making work accommodations, such as taking leave or figuring out how to retire or having to retire early, giving up promotions, arriving late for work because of caregiving responsibilities. And then finally, we also know that caregivers spend an average of almost $8,000 out-of-pocket costs related to caregiving, which is nearly actually 25% of their income due to a recent report. So a quarter of their income they're spending on rent, mortgages, medications, home accommodations, just because of their role as a caregiver. So briefly, what do they do? I won't be going through this list, and it's certainly not exhaustive, but we know that caregivers, in a nutshell, they monitor symptoms and side effects that caregivers have when it comes to different treatments. They communicate with the medical team. They provide emotional support and help to coordinate care. So they have a lot of different responsibilities and are responsible for a substantial part of the care for their relatives and friends. And although they provide a lot of care, actually more care than the health professionals themselves, their worth is often overlooked by the healthcare team. So this is somewhat of a sad slide, but a dose of reality when we think about the negative and positive aspects of caregiving. So we'll start at the bottom and end on the top. How about that? So caregivers often feel unprepared for their role. They experience psychological distress, and they experience physical and financial strain and burden. We know that caregiving can be very traumatic for individuals, and it can impact their mental health. But we also know there's a lot of benefits to caregiving. It provides a sense of self-worth, post-traumatic growth, which is a term that really focuses on positive psychological changes that's experienced by people following a trauma or a dilemma in life. It is through this that caregivers are able to obtain a sense of strength, value, and purpose as a caregiver. And it also allows them to understand and be prideful and have pride in terms of how they are really impacting another person's health. So these caregiving outcomes really are influenced by both demands and resources available. We know that when caregivers are experiencing certain outcomes, it has somewhat to do with the care recipient, but also what's available to them as a caregiver for support. And today, I really want to draw your attention to this word cloud, this illegible word cloud that talks about under-researched caregivers. The next slide will be a little bit cleaner to see. But I really wanted to draw your attention and see what words really pop out to you in terms of under-researched caregivers in the U.S. today. I'll name a few. So first, non-spousal caregivers. We also have those who are rural, those who are working full-time, those who don't have confidence in their role as a caregiver. These are all under-researched areas when it comes to caregiving literature today. And this is a neater slide where we can really see how diverse our caregiving population is, and knowing that they're not a homogeneous group. So the first caregiving population I want to draw your attention to is the caregivers who are considered part of the millennial caregiver generation. So we know that there's a changing demographic profile of the caregivers today. Baby boomers are shifting from being caregivers to care recipients. And we know that millennials do not necessarily expect to be caregivers. And we also know that different generations have unique needs. In the next slide, I'll outline that. But first, level setting in terms of how millennials fit into the whole kind of caregiving generations. We can see here that millennials are really, as of 2018, but currently now they're in their 40s, they're roughly in their mid-20s to early 40s at this point in time. We also know that there's other generations, as we can see here on the right-hand side, Generation X, Boomers, and the Silent Generation. So millennials are, for example, over 75 million strong. They're outstripping baby boomers. Currently, they're the country's largest living generation in the United States. 60% of first-time caregivers are either Generation Z or millennials. And 25% of Generation Z and millennial caregivers are actually caregivers for the first time since the pandemic, compared to 15% of Generation X and baby boomers. So the pandemic has really immersed this population even more. So who are millennials compared to other generational caregivers? First, millennials, about 57% of them have never been married. They're the most racially and ethnically diverse adult generation in the nation's history. They've been impacted by societal and cultural shifts. They've seen the war on terrorism. They've experienced economic recession. And they've witnessed a lot of landmark political changes. They're more educated than earlier generations that were at their same age. They're proficient in technology and internet, but they also face higher risk of mental health issues. In a survey, 72% of Generation Z caregivers in the United States, a different generation, said that they have worsening mental and emotional health issues since the pandemic. We also know, when we think about millennials in particular, that they're financially worse off than previous generations their age. And then finally, caregivers in general who are between 18 and 34 years old said that the pandemic made them feel burdened, compared to 57% of caregivers who are 65 years and older. There's been some literature on caregivers who are millennials. We know that they have high unreported needs. There's often a mistrust or skepticism when it comes to healthcare teams. They do desire transparency and do ask more questions in general. And they also seek to have an active role in healthcare advocacy and have different views on death and dying. So this slide here provides a brief overview, as some I've mentioned already. So we have, when we think about the caregiving in the United States today, we can see that there's a lot of growing trends in all areas, especially when we think about the number of caregivers, how often they are in terms of how many people they care for, the generational makeup of these caregivers. We also know there's a change in terms of working and employee. 61% of family caregivers are currently working, and they're juggling work and caregiving responsibilities. And interestingly, those who are simultaneously working full-time and reported one or more work strains are actually averaging about $10,000 a year on caregiving expenses, almost double the amount of caregivers with no or one work-related issue. And work-related issue can mean going in earlier, staying later, having to ask for time off. We also know, and thank you so much, Gary, for introducing and level setting the concept when it comes to LGBTQ partners. There's a growing literature, a lot who are collaborators of Gary and others in this room, who are studying the experiences of caregivers of people in the LGBTQ population. And these are just a few of the papers that are coming out and reports that are coming out. But almost 10% of caregivers in the United States today identify as LGBTQ. 45% of these caregivers have worsened emotional and mental health. They often feel, as Gary's mentioned earlier, they often feel unseen, unheard, not involved, removed, have visiting hours, not a part of family meetings, not a part of end-of-life care planning, and sometimes lack dignity and respect during the end-of-life care of their loved ones. And I won't go through this slide here, but I wanted to draw your attention to the fact that there's other diverse caregivers. I encourage you to take a look at these reports that are coming out as they are individually highlighting different caregivers. So this slide here talks about how there's different family structures and processes when it comes to caregiving, meaning caregivers are part of a different community sometimes based on race and ethnicity. But just a little bit of level setting right now, 40% of caregivers right now identify as non-white. So this is a growing population when it comes to the caregiving population. Hispanic caregivers are often younger, on average about 43 years old. Black caregivers are in their upper 40s and often single. Hispanic caregivers are often married and have other children under the age of 18. We also know that depending on, and you can read these slides, but depending on the background of caregivers, some caregivers feel kind of a familial obligation to take care of loved ones. And this can really impact how their perceived burden when it comes to caring for their loved ones. We also know that when they have a filial obligation to caring for others, it tends to help reduce their caregiving burden. And interestingly, down at the bottom, I wanted to make you aware that caregivers who are Black and Hispanic, Asian American, and Pacific Islander, for example, are likely to have multiple caregivers. It's likely to be a community. So when we're thinking about interventions, we need to look beyond dyadic interventions. And there are some caregivers who experience a host of racism, discrimination, which can lead to a lot of emotional and mental health challenges. Some of these caregivers of color, particularly Black caregivers, for example, often have a mistrust when it comes to provider experiences and lack satisfaction when it comes to services for them and their loved ones. And Heather Young has a wonderful article that I encourage you to read that talks about the heterogeneity of caregiving. In this framework, she talks about all of the different layers in which we should consider caregivers and where they stand in terms of social location, as Dr. Rosa mentioned earlier. So this slide really talks about the structural and interpersonal racism that affect the availability of resources for family caregivers. When we think about racism, we have to remember that this can really impact how many resources and supports caregivers actually have available to them. We know that the caregivers of color have higher demands, but they are also less likely to utilize formal services. And we also know that caregivers of color often require a level of trust that needs to be established with the care team. They also rely heavily on community partnerships to get through the challenges of caregiving. But they also face language and economic barriers to service use. I'll skip over this one. So in summary, there's less access and fewer resources available for families of color. There was a systematic review, as you can see here, that really highlighted that they may not only have access to fewer resources, but some of those resources are less effective or less available to them. We'll skip over this. I do want to highlight the role of palliative care in advancing health equity. Palliative care really strives on making sure that it promotes patient and family-centered care. And that includes listening and honoring the patient and family wishes and goals. That includes considering the cultural, existential, psychological experiences that families are experiencing, and also promoting a sense of cultural humility when we think about patients who are from different backgrounds. So strategies, a lot of strategies, and you will have these slides, but I think it's important first to acknowledge that there are important differences in caregiver populations. We need to think about how we're including them in research studies, how we're connecting them to the community, and how we're avoiding stigma and discrimination for these individuals. So the last slide really talks about key takeaways. And I mentioned discharge planning, and this is the hill that I will probably die on. Families of color do not want to be in the hospital setting. They want to be at home and in community. So when we think about palliative care, when we think about us as a whole, we need to prepare families to be at home and stay at home. And that includes being authentic, listening authentically, and knowing what is accessible and available to them in their own communities in terms of services and supports for family caregivers. And I'm really looking forward to the Q&A. Thank you so much for your attention, and I will hand it over to Dr. Estrada.
Okay. All right. How does this work? Just the app. Hey, well, hi everyone. My name is Leah Estrada, and I'm also very happy to be here with you all today. I'm going to be presenting on identifying inequities in nursing home palliative care for historically marginalized residents. So I don't have any conflicts of interest, but I'll share some of my identities also that I come with you today. I'm a Latina. I'm the daughter of immigrants from Guatemala and El Salvador. My parents didn't have the opportunity to to pursue higher education. My mother completed high school degree, and my father didn't have that opportunity. I grew up in a middle-class neighborhood in New York City, where at a young age, at 10, I became a caregiver for my grandmother, who had Parkinson's and dementia. And I continue to be an adult caregiver for my aging parents. My journey navigating higher education as a first-generation college student was not easy, but I persevered like so many others. And as a registered nurse, I had the privilege of working with patients and their families in their most vulnerable moments in the pediatric intensive care units. These experiences and identities shaped who I am and my research now, where now I am as a nurse scientist with a PhD, and where I've kind of experienced more privilege than I ever had before. And I'm thankful to all the mentors and generous community who have guided me along the way. And I try to use that privilege that comes with my education, my expertise, and my research to achieve health equity for older adults, and to give back all that I've received. So on to some background. So I'm going to start off with describing the state of nursing homes across the United States, which are an important care setting for older adults whose personal and medical needs increase with age. There's about 15,000 nursing homes across the United States for both short stay and long-term residents. So short stay usually receive care after a hospital stay, for example, and then they leave. But the long stay, which is my population of interest and what I'll be focusing on here, typically have more diverse range of care needs, including continuous personal and medical care, and they're unable to live independently. Additionally, quality of care issues are present across settings, for example, from rural to urban. So there's about 1.3 million Americans residing in these nursing homes. And it's estimated that 85% are over the age of 65, half of which over the age of 85. And approximately 25% of these residents come from historically marginalized racial and ethnic groups. And this has increased while there's been a decrease in older non-Hispanic white residents due to more care options such as home-based care and assisted living facilities. And it's estimated that 43% of Americans aged 65 and older will live in a nursing home at some point. So historically and currently marginalized racial and ethnic residents consist primarily of American Indian and Alaska Native, Asian, Black, and African American, Hispanic, and Native Hawaiian and Pacific Islander residents. So you can see the nursing home demographics nationwide on the left-hand side. And historically marginalized residents often enter the nursing home with worse health and multiple chronic conditions related to generational cycles of poverty, mistrust of healthcare clinicians and the healthcare system, and experiences of racism and discrimination that often lead to delayed care. And indeed, many of the historically marginalized residents are approaching the end of life related to poor health when entering the nursing home. And W.E. Du Bois back in the early 20th century was one of the first to recognize that these health disparities stem from social conditions and not inherent racial traits. And nursing homes are an important end-of-life setting for all residents, but particularly historically marginalized residents who often enter the nursing home in poor health. 25% of all deaths in the United States occur in nursing homes, and additionally 70% of all older adults with advanced dementia die in the nursing homes. Dementia is a manifestation of severe cognitive impairment. It's terminal, and across the nation, prevalence is highest in Black older adults, followed by Hispanic older adults. And end of life refers to the medical care and support provided in the time surrounding death. It's unique and personal for each individual, where most agree, though, that they would wish to avoid suffering during this time, and others wish to prolong life at all costs. In 1997, the National Academies of Science, Medicine, and Engineering formerly the Institute of Medicine, in their seminal report, Approaching Death, Improving Care at the End of Life, concluded that people approaching the end of life were not receiving high quality care that reflected their needs and preferences. And in their 2010 follow-up report, Dying in America, Improving Quality and Honoring Individual Preferences Near the End of Life, they concluded that the primary goal of end-of-life care is to provide person-centered, family-oriented care and provide comfort and maintain or improve quality of life. So that brings us to palliative care, which we all know. It's essential for high quality of care, and it's aimed at improving quality of life for individuals with serious illness, such as those approaching the end of life. And the National Institute of Nursing Research published a summary of research trends from 1997 to 2010, and they found that palliative care not only improves quality of life by better support and communication with healthcare teams, but it's also associated with lighter symptom burden and prolonged survival. So in theory, high quality nursing home palliative care should achieve health equity, particularly at the end of life. However, in a weighted national survey of nursing homes, we had identified suboptimal variation and wide variation in suboptimal integration of palliative care. So indeed, the end of life experience for the nursing home residents is often characterized by suboptimal management of distressing symptoms, increased suffering for patients and families, and then further outside of nursing homes, palliative care racial and ethnic disparities have been documented. So despite an annual $172.7 billion spent on nursing homes, nursing home inequities are pervasive for historically marginalized residents. Racial segregation, health-related deficiencies, and overall low quality of care. And during the height of the COVID pandemic, 40% of deaths in the United States were associated to nursing homes, and mortality rates were higher in nursing homes with higher proportions of Black residents. And these inequities, which are avoidable, unnecessary, and unjust, were present long before COVID and exacerbated after COVID. And in order to understand a little bit more about these nursing home care inequities, it's important to name levels of racism and its relation to the state of nursing home. So Dr. Tamryn Phyllis-Jones presented an allegory of levels of racism to gardening. So imagine a gardener with two flower pots. They pot new nutrient-rich soil in one and then leave the other one rocky and poor. And then they have two seed packets, red and pink, but they prefer the red. So they plant the red in the rich soil, and then the red flowers grow strong and tall, and then the pink ones barely survive. And then year after year, the same thing happens. And the gardener says, I was right to prefer the red flowers. Look how beautiful they are. And they even pluck the pink ones before they can go to seed and establish themselves. And in the end, it had all started with that poor rocky soil. So Dr. Phyllis-Jones identified 3 levels of racism in this allegory: structural, personally mediated, and internalized. In the context of the nursing homes, I'll focus on structural racism, which was presented in the segregation of the two flowers. That barrier and initial historical insult when the nursing homes were segregated, providing separate and unequal care, and then inaction in the face of need because nothing had been done to address the poor rocky soil and nothing has been done to address the pervasive health inequities for the historically marginalized residents who often reside in suboptimal nursing homes, leading to the poor health outcomes. So structural racism, as I mentioned, is the most fundamental of the 3 levels. It's a form of racism that is pervasively and deeply embedded in systems, laws, written or unwritten policies, and entrenched practices and beliefs that produce, condone, and perpetuate widespread unfair treatment and oppression of historically marginalized residents with adverse health consequences. And indeed, it's not always visible, conscious, or explicit. And structural racism has manifested in nursing homes through its racially segregated care system, where, for example, 14% of Black residents are concentrated in only 17% of nursing homes, a failed insurance payment system that leaves Medicaid-dependent nursing homes financially strained, and a lack of prioritization over low-resource nursing homes that typically house historically marginalized residents. So this has then resulted in historically marginalized residents residing in nursing homes that are racially segregated, financially strained, and poor performing. And then it's manifested at the resident level with increased morbidity and mortality among historically marginalized nursing home residents. So that led me to my objective, where knowing what we know about the state of nursing homes and how they're a setting that most of the all the residents need palliative care, I wanted to examine palliative care services provided in nursing homes across the United States and identify differences by the proportion of Black and Hispanic residents, respectively. So this was a cross-sectional nursing home facility level study using 2018 data assembled as part of a larger NIH-funded study. So for this analysis, we merged 4 data sets. First, a cross-sectional palliative care survey. And this National Palliative Care Survey was completed by directors of nursing from a randomly selected sample of nursing homes. Surveys were completed by either a mailed paper copy or an electronic version of the survey. Items used adapted measures from existing measures, and then they included 24 items on goals of care, decision-making at the end of life, spiritual care, symptom management, and advanced care planning. And content validity was established by a panel of 7 experts, and item refinement was conducted after being pilot tested prior to implementation nationally. And the survey had a 49% response rate. So the remaining 3 data sets were obtained through the Centers for Medicare and Medicaid. The second data set I used was the minimum data set 3.0 for resident characteristics. And this is a standardized screening and assessment health status tool in CMS certified nursing homes. The third data set was the master beneficiary summary file, which is high validity for Black and Hispanic residents. And this was used when race and ethnicity was missing from MDS. And then lastly, the certification and survey provider enhanced reporting data for facility characteristics. And this information is collected by quality CMS surveyors during nursing home inspection for CMS certification. So we then computed descriptive statistics to compare nursing homes and their palliative care services by the concentration of Black and Hispanic residents. Then we ran nursing home facility level multivariable linear regression models where a dependent variable was palliative care services. And this was a summative score of 0 to 100, where a higher score indicated higher provision of palliative care in the nursing homes. And independent variables were the concentration of Black and Hispanic residents. And they were categorized separately as less than 3%, 3 to 10%, and then greater than 10%. And previous researchers that have used MDS have varied in their construction of racial and ethnic concentrations. So therefore, consistent with previous research and then the distribution of the data, we calculated the facility level Black and Hispanic residents as such. And then our covariates were rurality and a binary indicator if the percentage of Medicaid residents was above or below the weighted national weighted median. And then to account for regional nursing home variations, all models were stratified by census region. So Northeast, South, Midwest, and West. And then population weights were also added to analyses to increase national generalizability of findings. So on to some results. So our final sample consisted of 869 nursing homes, representing a weighted national sample, over 15,000 nursing homes nationwide. And this included over 55,000 long-stay residents aged 65 and older. Most nursing homes were located in the Midwest, about a third were rural, and then on average, about 58.9% of the residents were on Medicaid. The South had the greatest percentage, there we go, of nursing homes with greater than 10% Black residents, and then the West for Hispanic residents. And most were not in rural settings. And then also as the concentration of Black and Hispanic residents increased, the percentage of Medicaid residents increased as well. So now I'm presenting on the distribution of the palliative care services, which was measured by the weighted unadjusted survey scores. So here we see palliative care services on the y-axis and then nursing home region on the, by the x-axis. So across the United States on average, and on a scale of 0 to 100 with a higher score, indicative of more palliative care services were lowest among nursing homes located in the South. And remember that these were also the nursing homes with higher concentrations of Black residents. And on average, palliative care services were highest in the Northeast and the West. Okay. And then here are the results of palliative care services by the weighted unadjusted survey scores by the concentration of Black residents, which again was categorized as less than 3%, 3 to 10%, and then greater than 10%. And here we see that nursing homes, in the Northeast and the West provided significantly less palliative care services with increasing concentrations of Black residents. And notice how the nursing homes in the South still provided consistently less palliative care overall. And then here are the results of palliative care services by the weighted unadjusted survey scores by the concentration of Hispanic residents, which was also categorized as less than 3%, 3 to 10%, and then greater than 10%. And we found that nursing homes in the Northeast and the West provided significantly less palliative care services with increasing concentrations of Hispanic residents. So now I'll present results from the multivariable linear regression models. So after adjusting for rurality and percent of Medicaid residents, and again with palliative care services measured from 0 to 100, where a higher number indicates more palliative care, relative to nursing homes in the Northeast with less than 3% Black residents, palliative care services decreased significantly by 9 points for nursing homes with 3 to 10% Black residents, and then 14 points for nursing homes with greater than 10% Black residents. And then in the West, palliative care services were 19 points lower for nursing homes with greater than 10% Black residents compared to nursing homes with less than 3% Black residents. And these significant decreases indicate significantly less palliative care provided in these nursing homes with higher concentrations of Black residents compared to those with less than 3%. Okay, and then these are the results from the multivariable linear regression models for Hispanic residents. So again, after adjusting for rurality and percent of Medicaid residents, and with palliative care services measured from 0 to 100, where a higher score indicates more palliative care, among nursing homes in the West, palliative care services were 9 points lower for nursing homes with greater than 10% Hispanic residents compared to nursing homes with less than 3% Hispanic residents. And again, this indicates significantly less palliative care provided in these nursing homes with higher concentrations of Hispanic residents compared to nursing homes with less than 3% Hispanic residents. So some key takeaways that we found were that Black and Hispanic older adults tend to reside in nursing homes that provide less palliative care. Regional differences of this association were present, where, for example, nursing homes in the South provided the least palliative care overall, and these nursing homes also had the most Black residents. Also, nursing homes in the Northeast and the West, with concentrations greater than 3% Black or Hispanic residents, were associated with less palliative care. And sadly, this is evidence that nursing homes serving more Black and Hispanic residents have less palliative care if the nursing home they reside in have more Black and Hispanic residents. And there's also some limitations to note. First, the palliative care survey may not capture all palliative care domains, nor take into account personal and cultural preferences, but it's still a reliable measure for the state of the palliative care in the nursing homes. Second, also the data sources were self-reported, which may lead to desirability bias. However, previous research has not found this in the past. Also, since this is a cross-sectional study, causal interpretations are not appropriate. And further, we did not include models on the concentrations of other historically marginalized populations, such as Asian and Indigenous communities, due to small sample size, unfortunately. However, our findings still suggest that greater investment in nursing home palliative care services is needed as a means to achieve health equity in nursing homes, particularly at the end of life. So building off the National Academy's reports previously mentioned, in April 2022, they released a new study report on nursing homes, the national imperative to improve nursing home quality, honoring our commitment to residents, families, and staff. And their findings and recommendations were aligned with these results in that nursing homes are providing suboptimal care that leads to disparities and unmet needs for historically marginalized residents, and reinforcing the need to deliver person-centered, equitable care that ensures quality of life. Basically, the nursing homes are not providing care that honors the dignity of the diverse older adult population. So these results also have some clinical research and policy implications. First, Black and Hispanic residents, they're receiving less palliative care depending on the nursing home that they reside in and how many Black and Hispanic residents there are. So comprehensive patient-centered care was recommended in that report, which is further aligned with palliative care practices as a means to improve nursing home quality of care and achieve health equity. Second, community and stakeholder engaged research is needed to understand why and how to resolve this. Also, just the best way to be delivering palliative care for these populations. So as we mentioned, it's multicultural. There's a lot of different facets involved. There's a lot of different parties involved. So that's something that we need to explore more and understand more so that we can deliver appropriate palliative care. And also anti-racist policies are crucial for implementing change. Where something to help the workforce, to honor the CNAs who provide the most care to the nursing home patients. And also currently nursing homes are not a one-size-fits-all approach. So we need to also be allocating resources to nursing homes that are more low resource and that need it as well. And just like to thank my co-authors who, without them, the work would not be possible, and then also funding from the National Institute of Health. And thank you.
Hi, everybody. Great job. Let's do a sound check on Zoom. Can the people on Zoom hear us okay? You could just let us know in the chat. Yes. Sound is good. Great. Think about how many people would love to mute me. They didn't have to listen to my keynote. So I was sitting there taking notes furiously on all of your research and your presentations. I was just so moved by the work you're doing and the passion you bring to the work that you do. So thank you for all that you do. And I thought before we give people in the audience here in person and on Zoom a chance to ask some questions, please do think of some questions either in the chat or in person. I just wanted to start with a general question, kind of a where do we start? So if I'm listening to you today, and if my organization wanted to create more respectful, more physically, psychologically safe, culturally safe environments for your population. So whether my organization's a healthcare setting or a research team or whatever it is, when we think about LGBTQ populations or caregivers or diverse older populations in nursing homes, what are the first steps of moving toward equity and inclusion? Why don't I start with you, Gary?
Okay. I would be really interested to have your institution start with an assessment of what it is doing in terms of servicing the community. You might put together a committee of LGBTQ staff and allies. You might include some patients. You might include some community organizations wherever you are, and to get a sense what kind of training is available at your facility? What kind of organizational non-discrimination policy exists in terms of protecting the LGBTQ community from discrimination? And I would say this is both at the patient level as well as for the employee level, because if an institution is treating its employees poorly, they also likely may be treating their patients badly. Look at training, look at how questions are asked about sexual orientation and gender identity. There are resources available to help organizations. SAGE in New York has a national LGBTQ resource center with lots and lots of information. But I would also encourage organizations to work with those organizations in their community, because they're the experts on the community needs, and they could really provide a lot of guidance on how your institution reaches out and serves the community.
Thanks, Gary. Yeah, and I really appreciate your point on how institutions are treating their LGBTQ employees. I think that's incredibly valuable to the conversation because we're all stakeholders in this, right? We're all a part of this, 50% of the problem, 50% of the solution, right? No matter where we are. Tamryn, what about for your population?
Thank you so much, Billy. I think that's a great question. I think there's a couple of questions we need to ask ourselves. First, who do we who are we around? How diverse are our social circles as clinicians, as researchers? How diverse is our team? How diverse is the clinical workforce that we're, if we're on a palliative care unit or an oncology unit, how diverse, is that? The other question is, for clinicians, we should be asking the patient, who's with you today? Not making assumptions, not assuming that it is someone's parent or child. It could be the neighbor. Yeah. The other question is taking an inventory, or the other suggestion is taking an inventory of what we have in terms of caregiver resources and supports at our institutions. And what do we, as professionals know about what's in our communities for families? So that onus is on us. And then, I think just making sure we have the right people in place when we think about patient and family advisory councils. Is it all caregivers of past patients who are from upper middle class? Do we have people who are diverse and come from different backgrounds who are on those advisory boards to really provide insight on caregiver experiences?
And Tamryn, thank you for pointing out the need to really become aware of community-based resources. I was just having a meeting with a colleague yesterday who took care of her mother post hip replacement, and the discharge team really didn't do any home assessment of stairs, of rehab and things like that. I mean, she was really left in a lurch in terms of being an adult caregiver for her mother. And so I think that's so incredibly important. Leah, what about you? First steps we can take?
Well, I was thinking of like either top down or bottom up, because top down to begin with, there's very little to any accountability within the nursing home settings. So it brings a lot of questions just in terms of just the resource allocation first and holding nursing homes accountable for providing this type of care. So that's from the bottom up, but more from the top down, but from bottom up is also I feel like Inego was just doing a basic assessment first of what is happening more at a granular level. This survey that I had analyzed, it's a starting point to just kind of see first what's the lay of the land and what's happening with palliative care. But more information is needed in terms of what are the preferences, what's the best way to address certain families, who's with the family, who's the caregiver, who's with, if the resident has family or friends, or who it is that they want to be involved in helping with that.
And it sounds like that's really a shared priority between what you're saying and some of Gary's research, where we don't want to make assumptions about who is at the bedside, what those relationships are, that we really have to ask questions and get curious, right? And surrender some judgment. Leah, there's a question for you from Judith Thorpe. They asked, were the nursing home staff trained in palliative care, and did that affect the outcome in your study?
I believe that was not assessed, right? If they were trained in palliative care. But that's something, I think, going back to your previous question, I think that's something that would also need to be like another survey, is to see how are nursing home staff being trained, if they are, and how, in what kind of capacity for palliative care. That's a great question.
I just want to open it up to the room before I carry on with some of the questions that we have here. Yes, please. You stole my question. And what's your name, please? Alana had a wonderful, for those of us on Zoom, Alana had a wonderful question about, not with any intent to diminish the disparities that our presenters really talked about, but really to identify a recent win or identify some hope in these populations. Did I get that right?
Yes, thank you.
Okay, great. Leah, why don't we start with you? We'll work backwards.
Like, that's a hard question. Oh gosh, a recent win for the nursing home community? Yeah, I'm like, if anything, I guess if you want to make a positive out of a negative, I think the pandemic helped bring to light a lot of what's been happening for decades. So I hope that that's something that doesn't die down and is able to kind of continue in making some real change. And then the National Academy's report also in the same timing is helped highlight a lot of that as well. So that gives me hope.
Yes, amazing. Thank you, Tamryn.
Thank you so much, Alana, for that question. I also think the pandemic played a big role in highlighting the role of family caregivers. So that is a big win. But also in fall 2022, we actually have there was a national strategy report focused on supporting family caregivers, the first of its kind to have hundreds and hundreds of recommendations to support family caregivers. So that is a huge win.
Wow. Wow. Thanks, Gary.
I think a huge win. When we think about the research, the two studies that my colleagues and I have done, the focus is on discrimination and bad care and situations of major exclusion in the healthcare system. At the same time, we asked them questions about the good care that they received. And I think what's so hopeful is the reports of really kind and compassionate care that people have received in getting care for serious illness. I was especially heartened, being that I come from the palliative care community, that some of those reports came in terms of the palliative care providers. And, it's my expectation that people in palliative care are going to be a bit kinder and a bit more compassionate than their colleagues in other specialties.
Yes, thank you. And Jane Peterson on Zoom pointed out the Moving Forward Coalition, the teams working on creating action plans for the goals in the NASM report, are working on how to embed person-centered care and training, reporting, surveys, et cetera. Other questions in the room?
This is Pat Stone. Thank you so much for everybody's expertise. I wanted to ask, I've been starting to do some work in hospice, different than palliative care. But, we know in hospice that people of color often go off hospice more frequently, are more likely to be hospitalized at the end of life. And I'm not sure if it's a preference or not. And I would like to just have somebody talk about maybe multicultural issues and preferences and what we could do to attack that issue.
Tamryn, do you want to start?
I'll start by first recognizing that there are tremendous disparities when it comes to end-of-life care and quality end-of-life care in our country today. But there's also assumptions that we make that people do want to die at home, and sometimes people don't want to die at home. And that could be related to who they have at home with them at the time. I think when we think about people who are not enrolled in hospice or who leave hospice early, some of that could be related to contextual issues in terms of how close they are from their family, how their cultural and spiritual needs are being met at the time. If they suddenly get better, people do get discharged from hospice. And certain, and words trigger, as Billy has mentioned earlier in the keynote, words are very triggering. So if we are constantly, saying, for example, Black families prefer more aggressive therapies, that is a word that is very triggering, and it could be preferences that may not be related to necessarily what we think of from a clinician standpoint. It could be something unrelated. We have to ask the questions in terms of what makes people choose certain decisions when it comes to end-of-life care. But you're absolutely correct. There are tremendous gaps when it comes to hospice use and end-of-life care quality and decision-making in our country.
Thank you, Tamryn. Yeah, and I think I would add too, I think some of what we see in hospice is also a reflection of poor integration of palliative care earlier in the disease process, right? If we're not eliciting values and concerns and goals, not only for the patient, but for their caregivers and communities earlier upstream, we leave everyone in a predicament when it comes to hospice and end of life. So I think some of it, in alignment with what Tamryn was saying, is about dropping assumptions, getting clear on our judgments, and asking more questions. I gave this example last week in Montreal at a palliative care conference, but one of my favorite images, if we think about all the things there is to know about a person, if you picture a pie chart, I heard this years ago, I love this.
But the things that we know about a person are about 0.01%. And in the pie chart, the things that we don't know about the person is about 0.01%. But the things that we don't even know are like 99.99%. And dropping our role as expert or as presumed expert in another person's lived experience to actually be with and learn from them as the expert in their care further upstream in the disease process, I think is so essential to fixing some of those problems that you brought up. There is a great question in the Zoom from Tess. I can't see, Panazales. Apologies if I mispronounced Tess, but I'm seeing a question. Have we actually measured the knowledge and understanding of different communities or populations in palliative care? So acknowledging that there exist biases because of lack of understanding. And this is also important for nursing home staff. So I think some of the question really speaks to how do we better educate palliative care teams in these multicultural approaches to inclusive care. Gary, you want to start?
I'm going to focus on advanced care planning. That's an area that's of special importance for LGBT people to be thinking about. And then a long time ago, I did a survey with a colleague of individuals on their knowledge about advanced care planning. And the LGBT sample had higher levels of knowledge of the documents part, advanced directives, than other surveys that were done with other communities. The issue is of whether that knowledge is actually translating into behavior of actually doing more advanced care planning. And I think that that is a bit of an open question. Billy, you have sent a study across my desk in the last day or so about advanced care planning, and I'm sure the answer to that is there. I don't have the author or the citation for it.
I was hoping you were going to read it, so I didn't have to. No, I know Dr. Carrie Kendrian is on that study. It was JAMA Network Open, but really about advanced care planning of sexual and gender minority populations. I think they surveyed about 200 participants across the country, really showing lower rates of advanced directive completion and advanced care planning discussions in those populations. And a lot of that has to do with the upstream factors we assume of lack of trust, lack of safety, and lack of, I think, cultural confidence in being able to be grounded in who they are, right? Did you want to answer, anybody want to answer that question about staff education to improve palliative care workforce understanding and mitigating bias?
Well, I was just going to add a little bit related to kind of the metrics. So as Gary mentioned, knowledge and, attitudes is one thing, but kind of going forward and, wanting to go, yes, let's do palliative care is a totally different layer. It could be, so, for when I think about metrics, we're not necessarily asking questions to populations that are on reservations, for example. I come from North Carolina. We have many reservations in North Carolina. So I know firsthand there are some groups of individuals that are not being asked the question as commonly as other groups of individuals from different racial and ethnic backgrounds. We also consider certain groups hard to reach. And again, words are triggering. It may not be that they're hard to reach. It may be that researchers don't want to go out there or don't want to ask the questions because they're afraid if they hear certain responses, they'll have to address it, or they'll have to look inwardly in their own kind of shame and how we're not doing things super well for different marginalized groups. So I just wanted to kind of point out that, we need to ask the questions, but also we need more funding for palliative care research to be able to support this work in terms of adapting current measures to certain populations, being able to honor people for their time who participate in research studies. So those are just some of my ideas.
Do you want to add,
Sure,
Leah?
yeah, I'll just say, kind of going back to the staff, but also the patients and the families, is to not underestimate. So I think it's been severely understudied, and I think something to take into account when, as we go forward and we're exploring this more, is to take into account the heterogeneity within different racial and ethnic groups. Like even within the Hispanic community, there's over 20 different countries that are represented. So it's not quite simple enough to just kind of lump everyone together. And within the Black and African American and Asian and Indigenous communities, it's like another layer that, again, we need the funding for, but definitely needs to be acknowledged in LGBTQ as well.
So we have about 1 minute left. So I want to build on Alana's question, just to do a quick round robin of just a brief statement of what each of you are really hoping for. So in your ideal world of surrounding your population of interest, what would it look like? What would good, inclusive, safe care look like? Anybody can start.
I'll start by saying amplification, amplifying the voices of family members, of people living with serious illnesses and recognizing them for who they are as individuals with multiple identities.
Nice. Thank you, Tamryn. Gary. Go.
Okay, I'd like to see training across the board for staff in hospitals and long-term care programs and hospices. I think knowledge is power, and I think if staff were better trained, and I mean staff at all levels, not just professional staff, if staff were trained to work with the LGBT community, that we would see some degrees of improvement in care for patients and for their partners and for their families, better treatment of employees, and more outreach with the community.
Thank you, Gary. And Leah.
I'll just, I guess simply put is just general recognition that palliative care is fundamental, particularly within nursing home settings. So everything else that entails in terms of staff training and everything and funding for this, but just acknowledging that it's a right that all residents deserve.
Yeah. So in closing, I'm hearing that that what we're really hoping for is a combination of the recognition of palliative care across systems and across cultures, the recognition of dignified personhood, and amplifying the voices of people with multiple interlocking and intersectional identities, and also really embedding education and cultural humility knowledge throughout the workforce and health system for inclusive care. And I'm really grateful to be moderating this discussion. Thank you.
I want to thank our panels, our keynote. Thank you all. It's been terrific. There's a few other people I want to thank too. Our co-sponsors, Sharon Sobel and Janice Grady from the Columbia Nursing Alumni Relations. They're help supporting this also. And of course, the support from the CHP, Bridget and Cadra. They've done a lot for this. I also want to thank the SIPSI team. This is our last event as a SIPSI center, and it's been really a pleasure to do this. And then I want to thank everybody that joined us today on Zoom and of course our audience. And for those of you that are here, we have lunch, so celebrate. Thank you.